So, welcome everyone. This is a podcast with Professor Lamb. We're here to talk about the uh, brand new Translate trial. So, I think there will be a lot of debate around this trial. So, please, can you please introduce yourself, Professor Lamb, and what was your role in the Translate trial, please?
Thanks, Ricardo. Yeah, thanks for having me. Pleasure to be on the podcast. So, yes, my name's Alastair Lamb. I'm an academic urologist until very recently based at Oxford University Hospitals and the Nuttall Department of Surgery. And I've actually just very recently started a new post at Guy's Hospital with my academic position at Bart's Cancer Institute, which has been great. So, yeah, the Translate trial, thanks for the chance to talk about this. As you say, it's been exciting for us over the last week, seeing or getting the chance to read out at EAU in Madrid and interact with folks about the sort of main messages and the possible implications. You asked my role, so I am the co-lead, the co-chief investigator of the trial, along with my excellent colleague Richard Bryant.
Okay, and tell us something for the ones who are hearing us. How does it differ from the other trials that have been already published in the literature? Why was it? How it differs, and what brings it? What does it give us more than the other trials?
Yeah, we need to be really sort of full disclosure, honest, that this was not the first randomized trial speaking into this space. We were sort of building off the back of three really excellent RCTs that published in the sort of first half of 2024, as you alluded to. So Probe-PC, Prevent and Perfect, the three Ps, as some of us say. And two of those from New York. So Probe-PC and Prevent, Beda Mian and Jim Hughes trials were both focused on infection as their primary outcome, and interestingly did not show a difference, or at least not in their initial publications, did not show a difference. But there was a perception perhaps that they were a little underpowered for that. Prevent did look at detection rates, but didn't see a difference. In fact, so Prevent was Guillaume Ploussard in Paris and Toulouse, a French randomized trial, and they did look at detection, but didn't find evidence of difference. In fact, if anything, they found that perhaps LATP was slightly worse in the posterior zone or posterior part of prostate detection. So the Translate trial, we kind of took this philosophy, which we think is important, which is that, as my colleague Richard has often said, a man doesn't have a prostate biopsy to avoid infection. He has a prostate biopsy to find out whether he has or hopefully doesn't have prostate cancer. And so we unashamedly plumped for that as our primary outcome. So detection of prostate cancer, specifically detection of what at the time we considered to be clinically significant prostate cancer when we set the trial up back in 2019, 2020. So Gleason grade group 2 or above. So that was our primary outcome, different therefore to Probe-PC and Prevent, the same as Perfect, but powered to detect a difference of 10% between the two ways of doing the biopsy, transrectal and transperineal.
Okay, well, and we'll go through the methodology of your study, but can you tell us a little bit how did you manage actually to standardize the biopsies across the 10 hospitals, because there were a lot of centers involved, and well, the same question in the same area of the question. Did the different centers were obliged to do fusion biopsies, or it was like every center could choose if cognitive or fusion biopsies?
Yeah, we intentionally approached the trial as a pragmatic trial. So, but of course, you're right. It's really important to have quality control in a trial like this, however pragmatic we set out to be. What were the pragmatic elements? Well, I suppose for the transrectal biopsy, unlike pro-PC, we didn't have microbiology targeted antibiotic prophylaxis. So it was dictated by each unit's formulary guidelines. So in the UK, as I suspect in other parts of the world, every hospital, the microbiologists get together and decide what is the preferred route of option for antibiotics in each procedure. So that was specific. Each unit followed their standard guidelines. For transperineal biopsy, we were, on the one hand, trying to push LATP as hard as possible. So we felt that in order for this trial to have maximum impact, we needed to foresee in advance what were the potential criticisms and ensure that we maximize the chance, if we had a positive trial, of people seeing transperineal biopsy in a positive light. And so two particular things. We decided no antibiotics whatsoever for transperineal biopsy, and we're pleased that in the end, almost 90% of patients did not have antibiotics. Those that did were on sort of clinician preference at the time for the procedure, so essentially a protocol deviation. And that was actually an idea that one of our excellent colleagues, Hide Yamamoto, at Maidstone in Kent, encouraged us to do. And it was a good idea, I think, because of, as we maybe come on to, the importance of antibiotic stewardship. So that was one aspect where we were really pushing LACP as hard as we could. And then the other was we ensured that we had, on average, the same number of biopsies for both LATP, local anesthetic transperineal biopsy, and TRUS biopsy, transrectal biopsy. And that meant, on average, 12 systematic biopsies. So we did allow systematic biopsies, and 3 to 5, averaging at 4 target biopsies. And as anybody who has a chance to look at our supplementary tables will have seen, that we did average those out at 4 biopsies per lesion for each of the 2 arms of the trial. And that was to ensure that nobody could say, well, if you get greater detection, it's simply because you're doing more biopsies with LATP.
Okay, and were you allowed to do cognitive biopsies or just fusion biopsies? I mean, did you need to have a software, or you were allowed to do a cognitive fusion biopsy?
Thanks. Sorry, yes, I didn't make that clear. This was all cognitive fusion. So none of the 10 centers used software fusion. But as many listeners will know, while a lot of us are excited by the possibility of software fusion, the evidence is still fairly weak to show that that is superior to cognitive fusion. And so we,
well,
again,
you know,
being a practical job.
What I truly think it depends on, probably even if the data is not there, but it really depends on the experience of the ones doing the biopsies. Actually, you need the fusion where you're probably, when you're at the beginning, then going through, you might not be needed anymore. So probably that's one of the possibilities. And as you said, I mean, the literature says there's no difference. So I completely agree with you. So, and let's go to the key findings of the study. So,
sure.
What do you think you found a higher detection rate for the transperineal biopsies? What are your thoughts about it?
Yeah, so shall I just quickly summarize? So we found Gleason grade group 2 or above prostate cancer in 60.1% of the local anesthetic transperineal biopsy arm LATP and 54.4% of the TRUS arm, so an uplift of 5.7%, and that's in the intention to treat population. We also did a per protocol analysis as well for those small number of patients who didn't have the biopsy that they were randomized to. So yeah, 5.7% uplift in LATP, and that was statistically significant. Interestingly, it was a little lower than our powered 10% uplift, but the reason it was, the reason we still saw statistical significance is because the control arm, the TRUS biopsy arm, with 54.1%, which is pretty good, isn't it? Was a lot higher than we anticipated from the cohort studies that we used to make the power calculation. One particular study that we used from Oxford. And we think that's probably because a lot of those studies were in the sort of pre-MRI era. So why do we see that? Well, I think it's almost certainly to do with anterior lesions and possibly due to apical lesions. And we are analyzing, so we have that data. In the paper itself, we see a trend towards a greater detection of Gleason grade group 2 or above in anterior lesions in the LATP arm, based on the data we've already published. But our current sort of analysis that is ongoing is to look at lesion-specific location on the MRI scans taken, obviously pre-biopsy, and do a essentially lesion by lesion detection rate for the two arms of the trial, and we'll have a follow-up publication, we hope reasonably soon, to confirm if that is indeed the case.
Okay, and how do you manage, because one of the main findings of the study is that transperineal biopsies are more painful and embarrassing. So how do you manage that, or how can you improve that? Do you have any advice for the ones that are hearing here? Because obviously that may be a problem in the everyday clinical practice.
It's so important. Yes, we found that patients on average said that LATP was more painful and more embarrassing when we asked them to fill in a questionnaire immediately after the procedure. Although when asked at 7 days and 4 weeks, patients had more symptoms with the truss in the truss arm. But yes, pain and embarrassment is an issue, isn't it? And I think those of us that perform LATP, and I learned a lot of these tips and tricks from Roberto Miano in Rome, and from Rick Popert at Guy's Hospital, a new colleague of mine since I've moved there. And it's and a fellow of ours sort of coined the phrase vocal anesthesia. I think the vocal anesthesia, as well as accurately placed local anesthesia, is key. And you can be good at it or not so good at it. I mean, little things. I've got a little YouTube video with some of these suggestions on my YouTube channel, but it's, one of the little things that I do is I put a black and white picture of a Scottish beach on the ceiling to distract patients, and I ask them at the beginning, where do you think the beach is? And usually they're thinking the Caribbean or somewhere in the Seychelles, and I sort of quiz them at the end. It's just something to distract. Other people have used 3D goggles, immersive experiences, to try and distract patients. And I think these are all really good ideas, and anything that we can do to improve the patient experience. And particularly because it is lying in lithotomy with your legs in stirrups is an undignified position. There's no two ways about it. And I suspect that is one of the main reasons. I think the pain is interesting. I think most patients, really the pain that they experience is more to do with the movement of the probe in their back passage, and actually that's present whichever form of biopsy you have. And often a lot of the local anesthetic that I place when doing an LATP is in and around the anal verge because of that, because I think that's the case. So I think it's important that as practitioners, if we're going to make LATP our standard approach going forwards, that we really think of ways to optimize patient experience.
So, and do you really think that this trial may be the final point, or the end of Troll's biopsies? Do you think that this is enough? Do you think that we need different trials? Do you think that we have to adapt to the method to the patient? What are your thoughts about it? And I mean, it's obviously a never-ending battle. It seems normally. There are still a lot of supporters of Troll's biopsies. So why do you think this is, and why people are still doing Troll's biopsies?
I'm biased, of course, but we powered this trial adequately. 1,126 patients, and we got a result for the primary outcome for which we powered the trial, and we provided important secondary outcome data to supplement the other trials. So I think the take-home message from the 4 trials now is that local anesthetic transperineal biopsy is slightly better at detecting MR visible prostate cancer, and is at least equivalent, if not better, than trust biopsy for infections without antibiotics. And Declan Murphy did an excellent discussant response to Richard Bryant's readout of the data at EAU and highlighted these two things. And he did an interesting thought experiment where he flipped things on their head and said, what if TP biopsy had been our standard for 20 years and we were doing trials to see whether we would switch to trust biopsy? And he advocated strongly that would not be something we would be keen to do. I would just add a caveat to that I still think we have a little way to go with the patient experience, and we must take that really seriously. I don't think this means, so in terms of trials, I think we've done the big trial. I don't know if there are some other trials ongoing. I'm not aware of any, but if there are, I don't think we need to set up any new trials for LATP versus trust. I think we've done the definitive trial. Is the data from our trial and the other three, so the 4 trials in combination, should that lead to a wholesale shift for everyone doing prostate biopsies towards trust? I'm not sure it should. I think it depends what you currently do and whether you do it well as a urologist or as a biopsy practitioner. And I think there are plenty of centers that have a very good trust biopsy practice with their own audit data showing adequate or low infection rates, who will see the data that we have published in the other 3 trials as legitimate reason to continue doing trust biopsy. And I can't fault that decision as long as they are transparent with their patients about the pros and cons. I think what this data now provides is essentially solid evidence that explains the trade-off between one biopsy approach and the other. There are pros and cons to both, and what we needed and now have is the evidence, the data, to make good decisions ourselves and for our patients. And I think also good decisions about what we train the next generation of urologists to do. I suspect the new urologists will be learning to do TP biopsy under local anesthetic as long as we can get the cost of the device, clip-on devices down. But I think we've got a little way to go, as I've mentioned a few times now, in optimizing the patient experience and whether it's through anesthesia or sedation.
Okay, so let's move a little bit onto the future. Do you think that, first of all, there is any role for AI? And then what do you think about the learning curve? Because we were talking about because I always say that it's during my residency and when I was an early consultant, it's one of the most difficult procedures I learned, because at the beginnings it's pretty difficult, but I think that with the new precision point and these aids, it becomes an easier procedure. So what are your thoughts about it?
I mean, AI is a buzzword, isn't it? And I think we've always got to be careful to define what we mean by artificial intelligence. So, whether we're talking about convolutional neural network approaches, algorithms, image segmentation, machine learning. But I think if what we mean by that is using clever computational algorithms to better target, train actually, and then target individuals who are doing TP biopsies or whatever form of biopsy to hit lesions. I think particularly in training and possibly in terms of real-time image segmentation, perhaps likelihood of hitting a lesion, so success rate in real time, and whether or not another target biopsy is needed. If you have a greater than 95% chance that biopsy has hit the visible lesion, another one, that could be really useful. But as we said earlier, as we found out with the software fusion modalities, actually there is no substitute for expert practitioner judgment. I mean, I don't know about you, Ricardo, but I've certainly found with some of the software fusion approaches that the kind of purple outline, the contoured region that I'm aiming for under LATP is sitting outside the prostate because of the deformation.
No, there's a big problem, I think, in software infusion softwares. I really believe it's like something that no one wants to talk about because it's industry driven, and so probably one of the main problems is that I remember that one of the best software fusions was back at Cambridge where we met. So that was that was a real fusion one, that with the grid, but that becomes very difficult in everyday clinical practice. It becomes complicated. It becomes costly. So actually, when you actually have a good level of biopsy, when you have a good level of rectal ultrasound management of the probe and of the needle, I think that you can easily target the lesions without any problems. And in these cases, I don't think there's any benefit in the fusion software. I mean, if you're really able, it's useful probably to have the MRI at your side, but no more. I don't think that you need any more anything else. So, and probably
I think, yeah.
So go ahead.
I think there are companies that are clearly trying to address this issue of, let's call it dynamic contouring or dynamic registration. It is a work in progress, and some have made. I don't want to mention one because I should then mention all of them, but some have made some good progress in dynamic registration, haven't they? But I think it's compensating for. So essentially, if the prostate's not moving, the probe's not moving, like as you said, when we use the grid, the brachytherapy stepper and grid, as we used to in Cambridge, and many others do when under anaesthetic, it works a treat. But the problem is with the local anaesthetic TP methods, we're certainly single freehand, if not double freehand, and therefore that means movement, and that means deformity of the prostate outline. And my experience is so far that the contouring and registration can't cope with that. But of course, AI forms of AI will, I'm sure, improve that, and if not in real time, certainly in training. And just to come back full circle, question you asked me near the beginning about ensuring quality in the trial, and this is going to be important for ensuring quality and delivery of biopsy services going forwards. There is a learning curve, so we made sure that every PI at every centre in the trial was signing off those who were delivering prostate biopsies, both TRUS and TP, as competent, which generally meant people who'd done at least 50 biopsies, so quite a lot. The exception being occasionally when people had done quite a lot of GATPs and didn't need to do a whole 50 under local anaesthetic to be competent. There is a learning curve, but I think that's true with a lot of surgical procedures, and we have good models of training and mentorship generally in our centres, don't we? And I wonder if actually a lot of the learning curve is again more to do with the interacting with the patient and ensuring that they have a good experience during the procedure.
Yes, so I think that we can just go through the end of the podcast. So, what's for everybody the key takeaway of the Translate trial, and what people should know about these trials?
Thanks. I'll give you a summary sort of visual abstract that you could perhaps put in the show notes, Ricardo, which we put on social media at the time of the trial. But the top line message is the primary outcome. We saw an uplift to 5.7% in detection of clinically significant prostate cancer, Gleason grade group 2 and above prostate cancer. Infection rates were lower, not statistically significant, but lower with the TB, and that was with no antibiotics. But LATP was a little more uncomfortable and embarrassing for patients. So I don't think TRUS is dead. People who perform TRUS well have reason to continue to do so. But I would imagine that over the next few years, people will gradually continue to shift to LATP. So let's watch this space.
Yeah, I think that it's gonna be. I think there is still a long way to go, probably. I think that people like to do what they are used to do, but I think that the results of the trial are strong. Actually, the guidelines are clearly moving to the transperineal biopsy indications. As you said, it doesn't seem like malpractice to perform a trans biopsies, but I think that informed decision making is essential, probably. So probably let's discomfort. But as you said, we're not having a biopsy to avoid infections or to avoid anything. Probably if we could just avoid those improve, let's say, the indication of biopsy. So select those patients that really need the biopsy. So improve a little bit of our MRI reading and this stuff, we would have less biopsies, and maybe we can perform them with a sort of light anesthesia, because probably light anesthesia, like what you do for a colonoscopy or a gastroscopy, probably that may improve quite easily the acceptance of the patient and the comfort of the patient. So I think it's just about dedicating a little time, and probably it's everybody wants to go on cystectomies and robotics, but biopsies are like a big world. If you dive into the biopsy world, you can really make the difference. I learned how to do the anesthesia with Roberto Miano, so I really know it changed completely my way of seeing it. They have like a meticulous way of doing it, so it's not just about putting the needle. It's not about putting the needle inside. It's about doing a real local anesthesia. And thank you very much, and hope to hear from you soon. So please consider, as you say, if you want to consider for sub-analysis of the trial our journal, you're welcome. So we're very happy to have some of your sub-analysis.
That's kind of you. We'll definitely be looking for places to publish our follow-up studies. So
just send us
that in mind.
So yeah, keep in mind, because we're very happy. We have a very big collection of biopsies, and we're very interested on the topic. So it's very good. Okay, thank you very much.
Nice to see you. All the best. Bye-bye.
Bye-bye.